Greetings, listeners. This is Dr. Adam Wilson bringing you a narrated self-study on the cranial cavity. In this session, you'll be introduced to the three cranial fossae and their associated structures, including their mini foramina. You'll be responsible for knowing the structures transmitted through each opening and the course that these structures take on their way to their final target organs. This presentation will also describe at length the importance of the meninges and the folds and sinuses they create. Of particular clinical significance is the cavernous sinus, which will be described in detail. Lastly, I'll describe the arterial supply of the cranial cavity, which will be complemented by a discussion of the four types of intracranial bleeding. To begin, recognize that the skull is divided into two parts. The visceral cranium is made up of 14 facial bones. The neural cranium, which is the focus of this self-study, is comprised of 8 cranial bones that form the cranial vault in order to protect the brain, its meningeal coverings, and associated structures. The bones of the skull cap, called the calvaria, are trilaminar. They consist of an outer table and inner table of compact bone, separated by a layer of spongy bone called the diploe. The diploe helps to lighten the skull and contains red bone marrow. Inside the bowl-shaped cranium are 3 large depressions called the anterior, middle, and posterior cranial fossae. Each cranial fossa houses a number of structures that communicate with either the brain or the walls of the cranial cavity. Let's take a closer look at the features of each cranial fossa. The anterior cranial fossa is made up of 3 bones, the largest of which is the frontal bone. The other 2 bones entail the ethmoid bone and the lesser wing of the sphenoid bone. Along the floor of the anterior cranial fossa is a vertically oriented projection called the crista galli. This means coxcomb in the Latin. This midline process of the ethmoid bone extends from the cribriform plate to provide a point of attachment for the falx cerebri, which is one of the 4 dural partitions in the cranial cavity. More on that in just a moment. The cribriform plate of the ethmoid bone is perforated by 15 to 20 foramina, which transmit the olfactory nerves from the nasal cavity to the olfactory bulb. The olfactory bulb overlies the cribriform plate. Though it is not well visualized in this image, there is a small pit in front of the crista galli between the ethmoid and frontal bones called the foramen cecum. This opening communicates with the nasal cavity and transmits an emissary vein from the nasal mucosa and frontal sinus to the superior sagittal sinus. More on that in a moment as well. Another notable pair of structures in the anterior cranial fossa are the anterior clinoid processes that project from the lesser wing of the sphenoid bone. Similar to the crista galli, these processes provide a point of attachment for a horizontally oriented dural partition called the tentorium cerebelli. And lastly, I'll mention the majority of the anterior cranial fossa cradles and protects the frontal lobes of the brain. The middle cranial fossa receives the temporal lobes of the brain and has a number of foramina, mostly for the transmission of cranial nerves that originate from the pons. The anterior aspect of the fossa is bound by the body and greater wings of the sphenoid bone. The posterior floor of the middle cranial fossa is formed by the petrous portion of the temporal bone, named this because of its petrous, rocky-like appearance. The lateral walls of the middle fossa are formed by the flat, squamous portion of the temporal bone, as well as the parietal bone. The anterior-most circular-shaped opening in the sphenoid bone is the optic canal, which conveys the optic nerve and the ophthalmic artery for communication between the middle cranial fossa and the orbit. A much larger opening, called the superior orbital fissure, transmits 4 cranial nerves and ophthalmic veins to the orbit. 3 of these 4 cranial nerves, including the oculomotor nerve, the trochlear nerve, and the abducens nerve, provide motor innervation to the 6 extraocular eye muscles. The ophthalmic nerve, however, conveys sensory information from the orbit and face. All of these nerves are transmitted through the superior orbital fissure. The foramen rotundum is unfortunately out of view in the image of the skull, but it can be located between the superior orbital fissure and the foraminal valley. The foramen rotundum transmits the maxillary nerve, abbreviated V2, from the middle cranial fossa to the pterygopalatine fossa, where it disperses into its branches to supply the structures of the maxilla. The oval-shaped opening, called the foramen ovale, conveys the mandibular nerve, V3, to the infratemporal fossa, where its branches innervate the muscles of mastication, as well as the teeth of the lower jaw, the tongue, and a number of other structures. Unlike most foramina in this region, which serve as exit points for a number of nerves, the foramen spinosum serves as an entry point for the small middle meningeal artery. It allows this artery to enter into the cranial cavity in order to supply the meninges of the cavity. Between the left and right middle cranial fossae sits a depression called the sella turcica because its shape resembles that of a Turkish saddle. The deep central depression of the sella turcica is specifically called the hypophyseal fossa, which accommodates the pituitary gland, also called the hypophysis. The anterior and posterior boundaries of the sella turcica are the tuberculum sellae and the dorsum sellae, respectively. The two tubercles on each side of the dorsum sellae are called the posterior clinoid processes. Lastly, the foramen lacerum is an irregular-shaped opening that flanks both sides of the sella turcica. In life, the foramen lacerum is not a true opening. Rather, it is closed by a fibrocartilaginous plate, which forms a boundary for the carotid canal through which the internal carotid artery passes. It's also worth mentioning that a structure called the greater petrosal nerve also passes through a small region of the foramen lacerum on its course to unite with the deep petrosal nerve as they enter the pterygoid canal. As you'll soon learn, the greater petrosal nerve carries parasympathetic fibers that are destined for the lacrimal gland in the orbit. The posterior cranial fossa receives the cerebellum and the occipital lobes of the brain. The large, centrally located foramen magnum transmits the spinal cord as it emerges from the medulla of the brainstem. Notice there are also 3 additional foramina in the posterior cranial fossa. These 3 foramina in total will convey 6 different cranial nerves. Just inferior to the petrous ridge of the temporal bone is the internal acoustic meatus, also called the internal auditory meatus. This opening conveys the vestibulocochlear nerve to the inner ear, and it also transmits the facial nerve through the bony facial canal. Located inferiorly to the internal acoustic meatus is the larger jugular foramen. This foramen conveys the glossopharyngeal nerve, the vagus nerve, and the spinal accessory nerve. It allows them to exit the cranium. In addition, the jugular foramen also receives the sigmoid sinus, which marks the start of the internal jugular vein, which is responsible for draining the majority of the brain. The last opening is the hypoglossal canal. This canal is going to convey the hypoglossal nerve. This nerve, as you can surmise from its name, is going to be destined for the tongue. The hypoglossal canal is located at the rim of the foramen magnum. Because of the abundance of venous drainage that flows from this region, there are a number of identifiable grooves where dural venous sinuses course. The most notable of those grooves are the sigmoid and transverse venous sinuses. The 2 transverse sinuses unite with 3 other sinuses in the midline of the occipital bone to form the confluence of sinuses that rests against the internal occipital protuberance. We'll talk more about those sinuses in just a moment. And lastly, I'll mention the clivus. This is a downward sloping surface from the dorsum sellae to the foramen magnum. Resting against the clivus is the basilar venous plexus of veins. Now that the bony framework has been laid, let's move on to explore the cranial meninges and their role in forming the important dural venous sinuses of the cranial cavity. As you may recall from our discussions of the spinal cord, there are 3 layers of meninges. Functionally, the cranial meninges protect the brain, they form the boundaries of the dural venous sinuses, and they create a barrier to contain cerebral spinal fluid, which bathes the brain. The pia mater is a delicate investment that is closely applied to the brain and dips into the fissures and sulci. The arachnoid mater is a film-like, transparent layer that is connected to the pia mater by web-like trabeculations. Between the pia mater and the arachnoid mater is the subarachnoid space, filled with cerebral spinal fluid. Cerebral spinal fluid is formed by the vascular choroid plexus in the ventricles of the brain, and it circulates throughout the ventricles and throughout the subarachnoid space, and is eventually reabsorbed into the venous system via the arachnoid villi. The toughest and most durable of the three meninges is the dura mater, which lies superficial to the arachnoid mater. In the living, there is a potential space formed between the dura mater and the arachnoid mater, called the subdural space. This space is a potential space because the pressure of the cerebral spinal fluid pushes the arachnoid mater firmly against the dura mater. Similarly, the epidural space is also a potential space. This is the space between the dura mater below and the calvaria above. The epidural space will contain the meningeal arteries. In the cranial cavity, the dura mater is bilayered. It is composed of a periosteal layer that is adherent to the inner surface of the calvaria and is also composed of an inner meningeal layer. It is the meningeal dura that is continuous with the dura mater of the spinal cord, as is illustrated by the blue lining in the lower right image. There are a number of instances when the meningeal dura separates from the periosteal dura to form blood-filled dural venous sinuses. This image demonstrates the superior sagittal sinus that runs superficially between the two hemispheres of the brain. Also notice that two layers of meningeal dura fuse to form a dural partition between the left and right hemispheres of the brain, called the falx cerebri. In total, there are 4 dural partitions. The largest of the dural folds is the falx cerebri. This sickle-shaped partition is a midline fold that runs in the longitudinal cerebral fissure between the hemispheres of the brain. It attaches from the crista galli anteriorly to the tentorium cerebelli posteriorly. It encloses the superior and inferior sagittal sinuses along its upper and lower borders. The tentorium cerebelli is a crescent-shaped fold that is horizontally oriented. It supports the occipital lobes of the cerebral hemispheres and covers the cerebellum. The free internal border of the tentorium cerebelli bounds the tentorial notch and is anchored to the anterior clinoid processes. The external border, however, encloses the transverse sinuses posteriorly and the superior petrosal sinuses anteriorly. The falx cerebelli is a smaller sickle-shaped partition that divides the cerebellar hemispheres. Along its posterior border, it contains the occipital sinus. The 4th dural partition is the diaphragma selae, which is a horizontal fold of dura that forms the roof of the sela turcica, covering over top the pituitary gland. It has a central aperture that allows for the passage of the infundibulum of the pituitary. Collectively, these dural folds help to accommodate the dural venous sinuses. In general, the dural venous sinuses receive venous blood from the brain and ultimately empty into the internal jugular vein that exits the base of the skull through the jugular foramen. Each sinus is bound by tough, rigid walls of periosteal and meningeal dura, which are lined internally by endothelium. The dural venous sinuses lack valves and, as was already mentioned, are the route by which cerebral spinal fluid enters the venous system. The superior sagittal sinus follows the upper border of the falx cerebri, running from the crista galli to the confluence of sinuses. The superior sagittal sinus receives the cerebral veins. The inferior sagittal sinus is much smaller than the superior sagittal sinus, and it runs in the inferior free border of the falx cerebri. It ends in the straight sinus. The straight sinus runs along the line of attachment of the falx cerebri to the tentorium cerebelli. The straight sinus receives the inferior sagittal sinus and the great cerebral vein of Galen, which happens to drain the brain directly. The straight sinus then drains into the confluence of sinuses, which also receives the paired transverse sinuses. These sinuses follow the lateral margins of the tentorium cerebelli and become the sigmoid sinuses as they approach the posterior aspect of the petrous temporal bone. The sigmoid sinuses follow an S-shaped course and continue inferiorly as the internal jugular vein after traversing the jugular foramen. The occipital sinus is found along the posterior border of the falx cerebelli, and it ends superiorly in the confluence of sinuses. Inferiorly, the occipital sinus communicates with the vertebral venous plexus. From this sagittal view, it is easy to appreciate the sigmoid sinus as it drains into the internal jugular vein at the jugular foramen. Also visible from this perspective are the inferior and superior petrosal sinuses. The junction between the superior petrosal sinus and the transverse sinus forms the start of the sigmoid sinus. The inferior petrosal sinus drains directly into the internal jugular vein. Together, the superior and inferior petrosal sinuses are responsible for draining the important cavernous sinuses. The cavernous sinuses are located on each side of the sella turcica and have connections with a number of venous structures. These sinuses communicate with each other via the intercavernous sinuses that surround the stalk of the pituitary gland. The cavernous sinuses are of great clinical significance because they communicate with veins that are external to the cranial cavity, such as the superior ophthalmic vein and the pterygoid plexus of veins located in the infratemporal fossa. Because there are no valves in the veins of the face, blood can flow in either direction, permitting infections that originate in the face to spread intracranially to the cavernous sinuses. An infection of the cavernous sinus can manifest as a cavernous sinus thrombosis. This condition can present with signs of cranial nerve palsies due to the fact that 5 different cranial nerves pass through the lateral walls of each cavernous sinus. In order from superior to inferior, the cranial nerves that traverse the cavernous sinus include the oculomotor nerve, trochlear nerve, abducent nerve, ophthalmic nerve, and the maxillary nerve. Additionally, the internal carotid artery passes through the center of the cavernous sinus. It is rare to encounter clinical scenarios where multiple cranial nerves are affected simultaneously, unless there is an anatomic commonality, such as the cavernous sinus, for example. As you practice identifying cranial nerve lesions, keep this concept in mind. To round out the discussion of dural venous sinuses, I want to present the definitions of 3 types of smaller veins that are found in the cranial cavity, and I also want to describe in more detail how cerebral spinal fluid is reabsorbed into the venous system. As we described in the introduction, the calvaria is trilaminar, made up of compact bone that constitutes the inner and outer table, and made of trabecular bone that constitutes the diploe. Not only does the diploe contain red bone marrow, but running through the diploe are ant-like tunnels of veins called the diploic veins that drain the calvaria. There are also emissary veins that connect dural venous sinuses with veins outside the cranium, such as veins in the scalp. The image in the upper right of the screen gives an example of a parietal and mastoid emissary vein which drain the scalp. Because emissary veins are valveless, blood can flow in either direction, creating the potential for external infections to spread to the cranial cavity. Bridging veins are the venous connections between the superior cerebral veins and the superior sagittal sinus. Both the calvaria and the meninges require a rich arterial supply. The largest and most notable of the meningeal arteries is the middle meningeal artery. Within the infratemporal fossa, the middle meningeal artery branches from the maxillary artery, and then it courses cranially through the foramen spinosum to reach the epidural space in the cranial cavity. Once inside the cranial cavity, it divides into an anterior and posterior branch. The anterior branch of the middle meningeal artery crosses the internal surface of the pterion of the skull. The pterion is a region of the lateral skull where 4 bones converge, including the frontal bone, sphenoid bone, parietal bone, and the temporal bone. The pterion is the thinnest and therefore the weakest area of the lateral skull. If an individual sustains trauma to the lateral skull, like from being struck in the temple by a baseball, the middle meningeal artery is at high risk for rupture, which can then lead to an epidural hemorrhage. Patients with an epidural hemorrhage are likely to present with confusion, drowsiness, headache, or a loss of consciousness. An epidural hemorrhage is an accumulation of arterial blood between the skull and the periosteal dura mater. When viewed on an axial section of a CT, epidural hemorrhages take on a lens-shaped appearance. This is because the parietal dura mater is strongly adherent to the inner table of the calvaria, thereby localizing the hematoma to a restricted area. Epidural hematomas tend not to cross suture lines because of how adherent the dura mater is in these particular areas. In interpreting the CT, you would also expect to visualize a shift of the ventricles and the falx cerebri away from the midline if the hematoma is laterally positioned. A second type of intracranial bleed is a subdural hematoma, which is the accumulation of venous blood in the subdural space. This can result from disruption of either the superior cerebral or the bridging veins. Shaken baby syndrome is an unfortunate but common cause of subdural hematomas in young children. Anatomically speaking, subdural hematomas take on a crescent-shaped appearance when viewed in axial cross-section. This is because the arachnoid mater is a weak film-like barrier, and venous blood can disperse around the entirety of the cerebral hemisphere, giving it a crescent, moon-like appearance. A shift of structures away from the midline is also common with subdural hematomas. In both instances, evacuation of the blood is a critical first step in reducing increased intracranial pressures. For the sake of completeness, it is also possible to acquire a subarachnoid and intracerebral hemorrhage. The rupture of a superficial cerebral artery would cause a subarachnoid hemorrhage, in which arterial blood fills the subarachnoid space. Upon CT imaging, a wave-like appearance along the lateral cerebrum is indicative of subarachnoid hemorrhage as blood fills the sulci of the brain. Blood can also fill the large fissures of the brain as well. Lastly, an intracerebral hemorrhage is the sudden leak or rupture of a cerebral artery within the parenchyma of the brain itself. In this instance, bleeding can extend into the ventricles of the brain. While uncommon, it is possible to have skull fractures along the cranial floor. One example is a fracture of the frontal bone, or even the cribriform plate of the anterior cranial fossa. Because the dura mater is tightly adherent to the bones of the skull, fractures of the skull often tear at the dura mater itself. And in this example, a rupture of the dura mater over the cribriform plate would cause cerebral spinal fluid to leak into the nasal cavity. Not only would the patient present with clear cerebral spinal fluid dripping from the nose, but may also be likely to experience anosmia, which is a loss of the sense of smell on the affected side. Well, thank you for listening. This concludes the self-study of the cranial cavity. Happy studying!